Victoria? Victoria, everything's good? Yeah. Okay, so I might as well start. So Dr. Tonks unfortunately hasn't he's caught in some traffic, so I'll just welcome everyone to Respirology regional rounds. I don't want to talk too much about myself, but I guess briefly, I finished my fellowship in respirology here a few years back, completed the clinician investigator program and the master's with Dr. Nair, and have an interest in severe airways disease, particularly sputum-based biomarkers in COPD. And so with that being said, my talk today is looking at the effect of the COVID-19 pandemic, particularly the first year, on community virus prevalence, so other viruses other than COVID, and respiratory-related healthcare utilization. And so here are my disclosures. None of them are particularly relevant to this talk, but I should mention one of the co-authors on the manuscript for this project that we submitted did get an unrestricted grant from AstraZeneca Canada to study respiratory viruses, and so I should just mention that part. And so the objectives of today's talk are to review some of the established respiratory virus cycles and their effect on respiratory-related healthcare utilization, specifically looking at asthma, COPD, and respiratory tract infection. And then second is to describe the study that we completed essentially, which is trying to look at this association between non-COVID respiratory viruses and respiratory-related healthcare utilization after the pandemic started. So really comparing the first year of the pandemic to years previous. But I'll get into the study objectives in a few slides after giving a bit of introduction. And so for a quick thing about respiratory viruses, many of you may not know that these are tracked by the Respiratory Virus Surveillance System, the Public Health Agency of Canada, and it's all publicly available essentially on the internet. They give weekly data reports. The important variables really being that for each virus, they'll look at the total number of tests and the total number of positives, for which you can calculate a prevalence. And they also release these reports weekly too. So on the top right, I kind of took a little screenshot of what that looks like. And in that report, they make even a summary of what are the problematic viruses at the time. So if you looked at the recent summary, they would be talking about influenza A and RSV. They also have some figures that show viral prevalence as compared to previous years, which is particularly important in this talk and with the pandemic. And then they also will give you some raw data as well, which we extracted for the purpose of this study. And so we have historical data on 8 different viruses. They're listed there. So the influenza A, B, and all the other different subtypes is RSV, of course, parainfluenza, adenovirus, human metapneumovirus, rhinovirus, and respiratory enterovirus, which are lumped together in this database, and then non-COVID coronaviruses as well. And so databases such as this one and others have established years in the past that a lot of these viruses have certain specific peaks. And so I'll go into that in the next few slides. And so this is a very busy table, but it just shows you kind of the depth of data that this website can provide to you. And this is just 1 week of data. And it shows along the top row just the different types of viruses. And in the first column, it's really just showing you the different provinces and specific different testing centers. And then it was all summed at the bottom for all of Canada's testing. So on a week-by-week basis. And here we are here in St. Joe's and completing a fair number of tests relative to the region. And so before the pandemic, respiratory viruses most of them followed a pretty, they adhered to a schedule essentially by season. And so if you start in the top left here for influenza A and B on this figure, the y-axis is percent positivity. So once again, it's the number of positive tests over the number of tests total. So that's one way to estimate the prevalence. On the x-axis is the months of the year. We decided to go back 5 years before the pandemic started, just so that we could kind of show that if there was a lot of variability. And so you can see that for influenza A and B, when they're combined at least, the peak for this is generally right after the new year or so. It stays high over Christmas, starts to decline in the spring, and then completely troughs in the summer. And if we look at RSV, pre-pandemic again, with the same axes, it again peaks after the new year, starts to decline and troughs in the summer. And then the same can be said for non-COVID-19 coronaviruses. So all three of these peak right after the new year or so, and then they trough in the summer. Two viruses that act a little bit differently is on the top is the rhinovirus and respiratory enterovirus. And this has a particular peak right in September or October, as you can see here. And this peak in virus and its subsequent effect on asthma exacerbations in children is being dubbed the September epidemic for this reason. And it coincides with the return to school, and that's being described, I guess, more than 10 years ago now. And then for metapneumovirus, it has an interesting peak in that it happens very often in the spring. And so we know pre-pandemic respiratory viruses are very closely associated with asthma flares, COPD flares, and respiratory tract infection. And if you look on the left figure, we have asthma emergency room visits. There's three different colors. Essentially, the purpley blue one is young children. The orange is 16 to 50, and the black is older asthmatics. So just looking at asthma emergency room visits by week. And if you look just at the purple line, you can see that around September, which is week 38, you can just see, is the spike of emerge visits for asthma in young children, and this is the September epidemic. And then the emergency room visits kind of go to an average level over the winter, and then the spring decrease slightly, and then usually trough in the summer. For older asthmatics, it's more likely to go to the emerge for a flare in the winter time. If we look to the figure on the right for COPD emergency room visits, these different colors in this case are not age groups. They're based on different cohort studies in different countries, so in Sweden and the United Kingdom, as well as Canada. And you can see that there's a very clear spike in COPD emergency room visits right around New Year's or Christmas time. And so to sum that previously established respiratory viral cycles, as well as healthcare utilization, asthma in children and younger adults, they peak in September, the so-called September epidemic, and that's associated with a peak in rhinoenterovirus and associated with the return to school as well. Then for COPD and respiratory tract infection, I didn't show data for the latter, but it looks very similar to the COPD graph. There's a peak in the winter, and that's associated with the three viruses that I mentioned before, the flu, RSV, as well as coronavirus. And so the Korean group actually looked at this respiratory surveillance system database, and they were able to calculate the total number of percent positivity. So looking at all 8 viruses together, pre-pandemic and during the pandemic for all of Canada. And so on the y-axis, again, is the test positivity rate. And then really the focus should be on this red line because that's 2020. And then all these other colors are years previous, essentially, so something to compare to. And the pandemic started roughly, week 10 to 13 of year 2020. And you can see that there's a marked decline in the respiratory positivity rate. And that stays low for a number of weeks after the pandemic starts. It spikes around week 39 again, so that would be around September, and then gets suppressed again, potentially for more lockdown measures at that time. But it's an obvious big difference between years previous if you look at all the other data points or data sets. And so what do we know about COVID-19 asthma and COPD? There's not very strong evidence that COVID-19 is more frequently occurs in patients with asthma or COPD. There's some evidence that non-type 2 asthmatics may be more likely to get it. And that for COPD, there's some kind of basic science evidence in the fact that the ACE2 receptor is upregulated in smokers and COPD patients, but we don't necessarily see that out. And and to try to figure out if someone just from a disease state is more likely to get COVID-19 from an epidemiologic point of view is difficult because there's so many behaviors that come into play when getting COVID, right? Especially in the beginning of the pandemic. We do know, however, that COVID-19, when patients with COPD are infected, generally do quite worse. And so this figure is from a nationwide Danish study with the absolute risk for the combined endpoint of severe COVID-19 ICU admission or death on the y-axis, and then time after COVID-19 diagnosis. And you can see that the highest risk group in the goldish orange is the COPD, and then after that, asthma and the lack of airways disease are pretty similar. And that makes a lot of sense, given that patients with COPD generally have fixed airflow obstruction, and so they have less pulmonary reserve, you could say. And so we know the pandemic has had a significant effect on exacerbations and healthcare utilization in general. That's kind of what sparked me to look into this. Really was the fact that on the wards, you'd see way less COPD exacerbations. And so if you just focus on the top row, because these are respiratory conditions essentially, so pneumonia, influenza, COPD, and asthma. And in the red is the actual number of admissions per 1 million. This is a South Korean insurance database. And then the expected is the blue, expected based on the years previous, as well as some modeling. And you can see that for pneumonia and all the other respiratory conditions, there's a significantly lower number of admissions that occurred after the pandemic started. So again, if we go back to this March level, it's already dipping before that actually. Influenza completely goes away essentially, and then COPD and asthma are reduced as well. And the reason to include it on the bottom, these non-respiratory conditions like DKA, intracranial hemorrhage, MI, and cancer, is that perhaps they behave very differently, right? So you could make an argument initially in the beginning of the pandemic that a lot of behavioral factors that keep people out of the hospital due to fear of getting COVID in hospital, not going to hospital unless you really had to, essentially. And while there's an initial dip in this red line in these non-respiratory conditions, kind of comes right back up to where it's supposed to be. And so that speaks to potentially a factor or a lack of something present that makes it so that respiratory conditions behave somewhat differently, and that they have a reduced healthcare utilization compared to other things. And so that got us thinking, is it the fact that we're all wearing masks and distancing that reduces non-COVID respiratory viruses, which generally have an effect on these top conditions? And so if you go specifically into the numbers, now that it's been studied a bit more heavily, we know that the estimates in reduction of asthma healthcare utilization, so both emerged visits and admissions, is about 50%. For COPD, emerged visits have been reduced by 55%. Admissions, there was a recent meta-analysis and it ranged anywhere from 27 to 78%, but I'll show you that on the next figure. And there's a lot of possible mechanisms for this reduced exacerbation. None of them are particularly proven, but there's things such as physical interventions like masking. There's other public health measures. I mean, we know what those are essentially, but like non-essential businesses, dining in, travel, things like that. There could be respiratory virus interactions. So specifically, there's this concept of viral interference. It's really the idea that it's difficult to get two respiratory viruses at once or one after the other, potentially related to the immune response that happens after the first virus. There's change in health behaviors. So for patients with asthma or COPD, they might be more adherent to the medications because they wanted to avoid hospitals so much. Or maybe they're more likely given action plans from their physician and then treat their own exacerbations at home. There's also the reduced air pollution as a possibility and the reallocation of healthcare resources to be more virtual or telehealth. And so this is the meta-analysis that I had referenced, showing that there's a reduction in hospitalized COPD exacerbations during COVID-19. You can see on the figure on the left that there's a big range. So the Spanish study showed a 78% reduction in hospitalized COPD. And the study in the bottom from Germany only showed a 27% reduction. I mean, a lot of these studies differ very much in their methods. A lot of them were single center studies or just 2 or 3 hospitals. Only 3 of them, the studies from Asia, so Hong Kong and China and Singapore, really talked about respiratory viruses at all. And essentially, there were single center studies, which where if someone got admitted with COPD, they would swab them and they would just would be reporting on that individual's positive test. And so it doesn't really give you an idea of the general how much virus is going on in the community. And so if you look in the pooled data here, you can see that all together they thought there was about a 50% reduction in hospitalized COPD when looking at all the different studies. And so this got us thinking to pursue a study that was in a large population, so Ontario, and also paired the virus data, so community viral prevalence, with healthcare utilization for those 3 conditions: asthma, COPD, and respiratory tract infection. And so the objectives of the study, which examined the prevalence of NCRV, so non-COVID respiratory viruses in the pandemic compared to prior, and then look at that relationship between changing NCRV prevalence as well as the changing healthcare utilization in those 3 conditions. And so it's a population-based retrospective time series analysis. Essentially, it was linking 3 databases and comparing the 5 years before the pandemic and then the first year of the pandemic. We looked at we got weekly respiratory virus rates from that surveillance system that I had mentioned before. The COVID-19 testing results were available publicly through the Ministry of Health on the internet as well. And then we had to request some data from CAI to get emergency room visits and hospitalizations for those 3 conditions, with the ICD-10 codes listed there. And so we defined the pre-pandemic period to be January 2015 to December 2019. And then the pandemic from April 2020 to May 2021. And then we also obtained timing of public health measures from CAI, which would tell us about things like dining in, school closures, etc. And so in terms of analysis, to calculate or to estimate the NCRV prevalence, we're just really looking at actual versus expected. In terms of percent positivity and the number of positive tests. So looking at it 2 ways, really, but obviously they're really very closely associated. And we calculated the expected based on the years previous. There was also we used a Poisson model also to take into account the seasonality as well as the increasing population of Ontario over those 5 years before the pandemic. We estimated the change in the positive cases from pre-pandemic to first year of pandemic, with the Poisson model giving us an incident rate ratio for the number of positive tests. And when looking at percent positivity, we used the binomial model, giving us an odds ratio. We also performed some sensitivity analyses by public health restriction, as well as by the different regions within Canada, which we really broke down by what were previously called LINs. So like healthcare centers, let's call them. And so we found, so this is very colorful and busy, but it's telling us about the prevalence of non-COVID respiratory virus during the pandemic. So percent positivity is on the Y, and then these are the years leading up to the pandemic. And then in this gray box is the pandemic itself. And so just to orient you to the viruses that I mentioned before, so in this teal is the influenza, in the gray is the non-COVID coronavirus, and this purpley blue is RSV. And so you can see that these 3 spikes are peaking every January, essentially, some bigger than others, right? And then rhinoenterovirus is in the yellow, and this is also generally peaking in the September region as well. So what I showed you before, what we expect to see. But when the pandemic starts, all the viruses essentially start going lower, obviously, except for orange, which is COVID, which didn't exist, obviously, before this. And then as it starts to climb up, all the rest of the viruses go down, aside from rhinoenterovirus, which comes back a few months into the start of the pandemic. And rhinoenterovirus for those who don't know, is like the most common cause for the common cold. Looking at the prevalence a different way, if you look in this figure on the left, all the viruses have been split up in this figure, and this is the number of positive cases we're looking at. And green was during the pandemic, and the dotted line is what we would have expected to see. And along the very top, you can see it's broken down into before lockdown, reopening, etc. And you don't have to look at all of them separately, essentially, because almost all of them, aside from rhinoenterovirus, go down once the lockdown starts and essentially stay down. But obviously, rhinoenterovirus is acting a bit differently. It comes down, but then it starts to come up again when there's reopening, but then stays down despite the second reopening here in March of 2021. And we can discuss that a bit more later on. And if you want to think about the numbers that are associated with this reduction, we calculated here the incident rate ratio as well as the odds ratio. You can see for almost every virus, so not looking at adeno or rhinoenterovirus, there's like a greater than 90% reduction in the number of confirmed cases as well as the percent positivity. Adenovirus is greatly reduced, but not to the same degree. And rhinoenterovirus, again, acting a bit differently with only a 49% reduction here and about an 80% reduction in percent positivity. If we look specifically at rhinoenterovirus from a percent positive point of view, again, this is the 5 year before the pandemic, and this is the first year of the pandemic. It behaves again differently in that all these other viruses no longer follow any seasonal pattern because they almost aren't there at all, right? While rhinoenterovirus still follows this pattern. And that's despite the fact that school didn't restart in September that year, right? So we had previously attributed it to a lot of snotty kids moving virus around, but perhaps that's I guess less important than we thought because there was no school, but the spike still existed. And so this is part of the sensitivity analysis, looking at the different regions within Ontario. So I grouped them up into Central, East, which is more like Ottawa. GTA has its own. The North, Southwest, and then I lumped Waterloo and Malden and Hamilton, Niagara all together as one as well. And you can see here that influenza, parainfluenza, and non-COVID coronaviruses are reduced across the board. However, these viruses in the yellow, including rhinoenterovirus, seem to have differing positivity rates depending on which region you're in. Some of these numbers, though, are difficult to interpret, like, for instance, this one, because there were very few tests for rhinoenterovirus, apparently, in the north of Ontario before the pandemic. So that's why these numbers are very skewed and difficult to really interpret. But essentially, the red ones, they're gone everywhere. The yellow ones, they still stay active in some different regions within Ontario. This table shows the effect of the public health measures on each of the virus. So it was like a hierarchical variable. Essentially, this is the least amount of public health measures, so the least restrictive, and this is the most based on schools, dining, and non-essential businesses. And again, there's a lot of data here, but essentially all the viruses are almost nothing, no matter what the measure is, the public health measure and the degree of restrictiveness. The rhinoenterovirus seems to be most present when there's the least amount of public health measures, and then gets reduced slowly as there's a greater restriction imposed by public health. That's a question, but probably or two. I'll just leave them until the end, I think. And so, looking at healthcare utilization, this is we'll start first with emergency room visits. And again, we have the years leading up to the pandemic and then the pandemic in the gray zone here. So we have COPD in orange, asthma in teal, and then gray is respiratory tract infection. And we can see that we know that they spike at certain times, right? So I immediately know that this is around January of each year. So COPD and respiratory tract infection peaking on a year-to-year basis. While for teal, asthma behave somewhat differently because young asthmatics and old asthmatics differ slightly, and that's why it's a little bit more of a bumpy road. But once the pandemic starts, all of them are significantly reduced. If you want to attach a number to that, the incident rate ratios are here. So there's like almost a 90% reduction in respiratory tract infection, 70 and then 60 for asthma. And very interestingly, you can see here that instead of having having peaks in January for these two conditions and peaks in September for this one, now they all have a peak in October. So it's a bit of all three conditions are coming together for some reason. And I'll get into why I think that's the case in a few slides. This is the same figure for admissions. So once again, the pattern established. And once again, pandemic starts and all admissions drop again. Essentially to a very similar degree to the emergency room visits. And so we also looked at the effect of the pandemic on asthma group by age. So we start here with emergency room visits on the figure to the left. And now the younger age group is in the orange, 0 to 15, and then 16 plus is in the teal. And we can see that they both are reduced during the pandemic. We're looking specifically at the incident rate ratios, which are reflected down here in the bottom left. You can see that the younger population has a greater reduction in asthma ED visits as compared to older asthmatics with the following incident rate ratios. And then if you look at the hospital admissions on the right, once again, everything drops. And although it looks a bit closer in this figure here, it's still to a much greater degree in the younger population of asthmatics compared to those that are older than 16. I did the same for respiratory tract infection. And so you can see here again, there's almost an equal amount in both age groups for emergency visits for respiratory tract infection, and both drop. Once again, it's greater in the younger population than the older population. And then when we look at hospital admissions for respiratory tract infection, those are generally a lot higher in younger people, as you can see, like from years previous. And then it just really bottoms out when the pandemic starts. Again, you can see here that it's greater in the younger population than the older. Obviously, I didn't do this for COPD since 0 to 15-year-old people usually don't have COPD. And so to summarize all the results that I've just presented, in the first year of the pandemic, there was a drastic reduction in all non-COVID respiratory viruses, aside from rhinoenterovirus. This reduction in non-COVID respiratory viruses is associated with a reduced healthcare utilization for all the three conditions that I looked at, RTI being the most, and then followed by COPD and asthma generally. There's the reduction in ED visits and hospitalizations is greater in children as compared to adults for both asthma and respiratory tract infection. And now this is combined or unified peak in October for all three conditions, which is associated with the reemergence of rhinoenterovirus. And so other studies have found also that non-COVID respiratory viruses are reduced with the onset of the pandemic. This very colorful figure on the right is from an American study. And the pandemic starting roughly around here, right? So there's, again, this dramatic cutoff. And there's really a loss of all the, let's call it virus diversity. You can see here that there's so many other colors essentially. And it gets replaced by green, which is COVID, rhinoenterovirus, and it's just a lot less diversity of viruses. For instance, influenza B here in navy blue is completely gone. The RSV type A is gone as well. But there's a lot more other subtle changes that are hard to really take out of this graph. But the fact is there's fewer viruses around. Overall, less positivity when compared to previous, and the seasonality has also changed significantly. In this US study, also rhinoenterovirus was the sole virus to avoid near complete suppression, just like what I found in Ontario. And then specifically for rhinoenterovirus, this is some more American data on the left here. there was an earlier rebound compared to our study in rhinoenterovirus, as well as persistence despite public health measures in the US. And obviously there's going to be a lot of differences country to country or even state to state in America when the rules, may differ very significantly in terms of public health measures. Now we're probably all getting to somewhat similar, but especially in the first year, there's such big differences. And that probably explains why the US had an earlier reemergence, because in a lot of states, there was an earlier, alleviation of public health measure restrictions. And so it seems like the pandemic, for whatever reason, the pandemic or the related public health measures were less useful for this virus. Interestingly, some tropical regions report on their rates of rhinoenterovirus, and they essentially stay very similar throughout. So the climate has some effect on it as well. And so the reason that rhinoenterovirus might be acting a bit differently is thought to be related to its non-envelope structure. So apparently that can increase the viral shedding time, and then also make it such that environmental is more protected against environmental stress. Also, the genomic diversity and the fact that there's usually multiple circulating strains can keep it around a lot longer in the community. The healthcare utilization data for rhinoenterovirus related visits to hospital essentially only exists for respiratory tract infection. There was one US study using administrative databases that found there's more ED visits secondary to rhinoenterovirus, but there's certainly some flaws in that study because they really kind of took EMR data, and whenever rhinovirus or enterovirus were mentioned, they consider that as part of their outcome. And obviously, when people come in, you can't always say that it's from rhinovirus for sure, because usually the PCR test comes back after they've left emerge, And then there was a single center in Beijing with a pediatric population that any patient who got admitted for RTI, they would do viral swabs, or if they ended up getting a bronchoscopy, they would do PCR and respiratory samples. And that's how they decided on the prevalence of rhinoenterovirus related admission and compared it to years previous. And they also showed that it was going up. But certainly there's some flaws of those types of studies. So similarly, we showed a reduced respiratory healthcare utilization. Unlike other studies, we looked at all these three common respiratory conditions rather than one at a time. I think that was useful because without looking at that, we wouldn't have seen that all conditions peaked at the same time in October again. We showed that there was reductions in emerged visits, most for respiratory tract infection, then COPD, then asthma. Hospitalizations, it was RTI, then asthma, then COPD, but the numbers were quite similar for asthma and COPD. And we established this new October peak when previously there wasn't a close connection with epidemics of the common cold and COPD essentially. It was more related to influenza wintertime. And so some of the strengths of the study is that we paired healthcare utilization for these three common conditions with community viral prevalence. We examined these three common conditions, like I just mentioned, and then we used a large population, so all of Ontario, which is 14 million people. And some of the limitations is we couldn't necessarily confirm asthma or COPD since it's all administrative database work. But at the same time, the same utilization of these databases has shown very clear peaks in healthcare utilization for asthma, COPD, and respiratory tract infection separately. We also can't comment on the mechanism, obviously, by which non-COVID respiratory virus is reduced, because obviously when COVID spikes, they're quickly followed by lockdown measures and changes in behavior. So is it the COVID itself? Is it the public health measure? Maybe a combination, but I probably lean towards the public health measure. And finally, I'll just talk a little bit about some of the recent headlines for non-COVID respiratory viruses. And so here's just a few headlines. The first one showing that, if you haven't heard in the news, that RSV is becoming a problem. It particularly affects children, infants with bronchiolitis, and that's put a lot of strain on hospitals in terms of pediatric wards in the ICUs. And the same thing is happening in the United States, right? So this article from NBC talking about RSV as well. There's also influenza spiking up as well. I mean, that's now coming down as well. But let's just say that just being on medicine wards recently, I've never seen RSV and influenza outbreaks, but now it's becoming more common. And then finally, the City News article talks about these 3 different viruses as part of the pandemic or epidemics. And I'll just finish with some of the data, recent data from this respiratory virus surveillance system. So this is within all of Canada and is up to date as of, I believe, last week. And so you can see here that perhaps rhinoenterovirus was just the tip of the iceberg in the beginning, and now there's all these downstream changes that we're seeing, and it's really affecting the healthcare system in different ways. Like the RSV example is a good one. And so we see for influenza, the blue line is this year. The black is 6-year average, and this is last year, the light blue, and then red is the very first year of the pandemic. And so you can see there is none. Then we have a peak in influenza A, which happens way after when we usually expect it last year. And this year it's happening before when we would expect it. And then when we look at influenza B, which is usually less associated with flu pandemics, it seems to be completely gone. And so this could have big implications on how we target our influenza vaccines, as well as the timing of these vaccines. We can't rely as much on the previous flu seasons to say when we should give the vaccine, right? Similarly, if we look at RSV, again, the same markers apply. So this is the current year in blue, seemingly starting before and now reaching levels as similar compared to the 6-year average. Last year, it started even earlier. And then the red is the first year of the pandemic, where it really wasn't there until the very end. And then for rhinoenterovirus, it's kind of fallen into a relatively similar pattern. You can see so peaking here. Maybe this peak is gone now. This would have been the October peak that we saw, but now it seems to be back to what it used to be, at least last year. And so it's behaving somewhat similarly, but seemingly a bit lower than what we would have expected in the past. And so just quick thank you to my co-authors who helped collect the data and provided lots of insight into the epidemiology part of things, as well as respiratory viruses in the data analysis. And then also thank AstraZeneca who given that unrestricted grant many years ago to Neil. And with that, I'm pretty much done. I can start with the questions. Yes. I don't know if the first one is I'll just read it. So Dr. Inman says, it seems possible that the lower prevalence of exacerbations may be based on people raising their bar in terms of how sick they need to be to go to emerge or clinic during the pandemic. If that were the case, then similar effects would be seen on exacerbations than other diseases. It might also be reflected in greater severity in the exacerbation that could present if only sicker people are seeking help. Yes, I think that's definitely the case, where patients with airways disease might, especially COPD, they might try to tough it out at home a bit longer. Like when I showed that figure that had respiratory and non-respiratory conditions below, essentially the non-respiratory conditions, it wasn't an exact fair comparison because almost all of those would just kill you if you didn't seek help, like DKA and intracranial hemorrhage. So those generally wouldn't, but even I was reading another study that looked at CHF exacerbations, which might compare similarly in that there's going to be dyspnea, potentially on the background of chronic dyspnea. And that was also still the case that there was a greater reduction in healthcare utilization for respiratory viruses compared to heart failure. Dr. Inman's next comment is, I don't I don't think that hesitancy to seek help would account for everything, but it could be a confounder in these studies. Yeah, it's really difficult to tease out exactly how much is related to hesitancy, especially with like this kind of population-based study for sure. Oh, you're deleting them as you go. I was like, what's going on? Okay, so Nathan, this is wonderful presentation. Could your data set methodology also be used to look at the association of respiratory virus infection and ILD admissions? Yes, for sure. I chose not to because I think that the numbers, I guess, would be so much smaller when compared to asthma, COPD, and respiratory tract infection. But I mean, it couldn't right now, let's say. We'd have to go back to CAI and ask for that data because they only pulled the ICD-10 codes that I requested. But essentially, it's not very difficult to do that. So, Dr. Inman, as they rebound, is there a change in the mean severity of cases? If pandemic measures have reduced global exposure to viruses, then antibody levels may be lower on average, and you would expect more severe infections. I guess as the viruses rebound, is there a change in the severity of cases? I mean, I couldn't answer that with the study that I conducted, but it seems that that is the case, right? Because RSV is similar to levels it was in the past, yet pediatric ICUs, from what I hear, have been really overwhelmed. And it makes even more, I was thinking about this immunologically, and it would make more sense that kids would get the most affected because, especially during the pandemic, if they had no contacts whatsoever to pick up other viruses and build immunity, then they would definitely be most affected by the reemergence of a virus rather than adult. Maybe I'm wrong, but this is just how it works in my clinician mind, is that adults who, might have had so many viruses in the past and have memory cells in place, they would do a little bit better when there was this reemergence of the virus after 2.5 years. And then Dr. I was saying name out, Dr. This guy. You showed a slide with a real change in viral ecology pre and post pandemic. Do you think that we will return back to pre-COVID ecology and pre-COVID hospitalization volumes now that the world is open, no social restrictions? I think that's, I don't know if I can comment. Not like at the end of the day, I'm not a virologist. I just it's really hard to say. But if we never go through lockdowns again, then really everything could only be attributed to changes in behavior for certain patients, and then also this concept of viral interference. Because again, anecdotally, a lot of even though everything is open again, many of my patients, especially with severe asthma, severe COPD, they behave exactly the same as they did previously. They mask and they complain about other people not masking. And so that's going to play, I guess, a role too in how things could be spread. But I think that is the minority of people, definitely. And Dr. Inman says, so protective measures are good in the short term, but when you remove them, you're in a lot of trouble. I think it's somewhat yet to be seen, but it seems that when you're in a lot of trouble, if we would be able to predict, I guess, which areas would be, I guess, where we would most be in trouble, that could help us kind of get through it. So if we could somehow have anticipated that RSV would be coming earlier and be sustained longer, then perhaps there would be a change in how we set up our pediatric ICUs. It could affect R&D in terms of getting RSV treatment. There is a monoclonal antibody for RSV, but I don't think it's used very commonly except in very, very specific cases. And so, yes, it seems like we're running into more trouble, but certainly with more research, hopefully we can get into a a space where we can predict which ones are going to be problematic, and then do some epidemic planning from that perspective. Okay, I'm done with the Zoom. So now we'll move on to, well, Victoria has a question. Who? Okay, sure, yeah. Oh, it's here?
Sorry, I'm connecting virtually.
I don't see it.
Can you hear me, Terence?
Oh, Dr. Gong, you can speak to ask the question.
Okay. Thank you, Terence. I don't know much about the CIHI database, but does that contain prescription, filling out of prescription data? Because I wonder, just following up on Mark Inman's comment, whether patients are holding out and going.
Sorry, Mylan, can you restart asking your question? Sorry.
Oh, okay. Can you hear me now?
Only through Victoria's computer. Hold on.
Okay, great. I don't know much about the CIHI database that you use to look at healthcare utilization, but does that have data on ICU admission, which would provide you with severity of the presentation as well as mortality? And also, does it all contain the number prescription filled? Because that may give you some insight as to whether patients are actually managing their exacerbations at home rather than coming into hospital.
So CIHI doesn't provide that level of detail. It's not as good as whatever like ICE is. It's definitely not prescriptions, not ICU either. I asked them about mortality, and essentially they said that they weren't able to do that either. We had to build in rules to make sure that we didn't double count patients who came to emerge and then get hospitalized, because even that was possibly a problem. So, we said that if you were admitted within X days of the emergency room visit, then we would count it as the same visit, essentially. Mm-hmm. And so that's just an example that the database isn't perfect, but it's probably only what I had available to me and with the budget that I had. So, right. So it's got some weaknesses to it for sure, but it really got me what I needed, let's say.
And I might have missed this because you may have addressed it with what Mark Inman was asking about the rebound post-COVID. I mean, the recent surge in RSV and all of that. Does your group have any idea as to the mechanism underlying that?
Short answer is no. We're talking about RSV, right? Not rhinoenterovirus.
Yeah.
Really, the study itself only lasted in the first year of the pandemic. That's as far as I went. So I can't really comment on RSV. All the rest of the stuff that I was talking about RSV is just to acknowledge that there's been more changes in viral ecology, even as we are coming out of the second and third years of the pandemic. Mm-hmm. So I don't know why RSV is spiking like this, but there's a lot of theories about whatever, previous exposures and an immunologic reason for that. Rhinoenterovirus, as I mentioned, is considered to be related to the fact that the non-envelope structure and its genomic diversity, etc.
Right. Okay. Thank you.
Welcome.
Can I comment on the fact
yes.
that I think the immunity debt conversation is one that's. There are many different populations that have different immunological stories. So the blanket mass being heard us and a really dangerous assumption because it's not consistent with a lot of the data. But a lot of the data on RSV, influenza, and flu infections being much more severe in children, and those two diseases overlapping is strong. And there is actually an epidemiological study out in Australia looking at this question about severity and finding that some presentations are increasing, those presentations are more consistent with coronavirus. So that's not supportive. And sorry, just one more comment. I think the other thing that's so interesting with the rhinovirus story that you've observed is rhinovirus and adenoviruses have these protein shells around them, so they're resistant to alcohol-based cleaning, all the anti-clean and all that stuff we do. And they're the two viruses that have the best data for fomite-based transmission as opposed to respiratory transmission. So I think one of the explanations for that is that the masks don't help you with the fomite transmission. That's not But the data for that is really clear that we have this long environmental latency period, and people have done studies in daycares where they go in, they clean the daycare with their alcohol-based cleaners or whatever they use, and they find that the rhinovirus is in the system and infect weeks or months later. So I think that helps sort of explain this non-envelope virus.
I'd like to share that, but it is, I don't think I can repeat what Dr. Bowders was just saying, other than the fact that she's saying rhinovirus, enterovirus, and adenovirus. There's good evidence that they can live longer on fomites and are resistant to hand hygiene, and so that could potentially explain what I saw in my study. And then there was also a comment on influenza RSV co-infections in the study in Australia having a really severe presentation. So I hope that was close.
And one more interesting piece of epidemiology that I find fascinating. So I studied pneumococcs, and all 6 continents have reported no change in carriage rates over the pandemic of 2020, which I found shocking. But invasive pneumococcal disease disappeared, just like you observed. And what's fascinating is it has come back in the same ways as RSV and some of those seasonal viruses. And so now our understanding has changed, that some of these bacterial infections are actually true co-infections that might have been detected before. And I think that your COPD patients, I don't really know about asthma as well, there is some evidence that disruptions to their airway microbiota due to the infection of the virus lead to aberrant inflammatory responses to the microbes, to the virus themselves. So I think that also speaks to a possible mechanism that we can contribute to understand about rhinovirus and its disruptive effects.
Yes, definitely. We, as clinicians, we always consider, like a secondary bacterial infection to a virus, and Dr. Bowders was just mentioning that the prevalence of Streptococcus pneumoniae seems to be returning in a similar pattern as many of the viruses, such as RSV, and I assume it would be also with influenza. So Dr. Nair has a question too, or a comment. Pavlizumab, as far as I know, is only approved for infants less than 2 with underlying medical conditions. Yes, I believe that's true, like congenital heart disease. I think Pfizer and GSK have released top-level data for RSV vaccine. They're currently under regulatory review for adults. Okay, good. That's another question. Excellent. I don't see any more. Oh, wait, here. Okay, so I don't see any more questions. We're almost time up anyway. Great, thank you very much. Thank you.